Welcome to Simcast, a podcast brought to you by the Society for Imaging Informatics in Medicine.
Welcome to another episode of Simcast. This is Jason here, and in today's episode, we'll be having a conversation with the folks from Mercy Ships. Mercy Ships is an international charity that operates the largest non-governmental hospital ships in the world. They provide humanitarian aid, such as free healthcare, community development projects, community health education, and we'll be having a conversation about how a floating hospital manages imaging workflow and challenges around that, and how they've been able to overcome some of these challenges. Our guests today are Kelvin Burton, Martha Henderson, and Graeme McKay. Kelvin Burton joined the IS team at Mercy Ships in East Texas in October 1990 as a volunteer after moving to the US with his wife and children from New Zealand. He has filled many roles in IS over the years since then and is currently business analyst in the Organizational Project Management Office. For the last 3 years, he has been focused on projects intended to improve the efficiency of the hospital related to activities on the ships, and the Radiology PACS replacement project has been a key part of that activity. Martha Henderson first volunteered in 2012 with Mercy Ships in Togo, West Africa. Over the next 10 years, she split her time working with the NHS as a CT radiographer in the Scottish Highlands and leading the radiology team on board the MV Africa Mercy. More recently, her focus has been setting up the radiology department on the Global Mercy, a new hospital ship that's recently gone live. While completing her master's in applied global health, she's interested in providing diagnostic radiology services in low-resource areas. And finally, we have Graeme McKay, having previously worked with innovative startup companies including MedCurrent, Biometrics, as well as industry leaders such as Bayer Healthcare and JP Morgan Chase. Graeme is combining his experience with a passion for healthcare and technology in his role as CTO and co-founder of Interlinks. Overall, this was a really good conversation. I always enjoy these when we're talking about how we can improve imaging informatics for those in developing countries. Welcome to Simcast. We have, I think, what's going to be a really interesting conversation today with Mercy Ships. And there might be a lot of people that are dialing into this and listening that are not familiar with Mercy Ships. So maybe to set the table for this discussion, could someone here provide a brief explanation about what Mercy Ships is, how long has it been in operation for, and what patients do we serve or do you serve?
I'll start off on that and then Martha can follow on. Mercy Ships was founded in 1978 with the purchase of our first vessel that was bought from a ship graveyard in Italy. It was the MV Victoria. We renamed it the MV Anastasis and spent 4 years with volunteers getting it up to seaworthy state off the shore of Greece, and then sailed it pretty much around the world, visiting different places, raising volunteers, support, getting donations of goods, and really just formulating the organization. We were, at that stage, the founders, Don and Dion Stevens, were leaders in an organization called Youth with a Mission, and it was the marine outreach portion of that organization. In 1992, we separated from Youth with a Mission and became our own nonprofit. In 1990, our focus shifted to primarily the African continent. We have had a number of smaller vessels over the years that served in Latin America and Caribbean areas like that, and one of them eventually ended up in the Pacific. But nowadays, our focus is almost entirely on sub-Saharan Africa.
Terrific. Okay. Go ahead, Martha.
Yeah, so Mercy Ships uses the platform of hospital ships in order to reach some of our patients. The majority of people living in low-resource countries live very close to port cities. So having a hospital ship platform means that we are able to sail to a particular country, stay there for 10 months, and reach the majority of the population, because generally a lot of them live within access to a port. In order to reach some of the patients in the interior of the country, we work with other NGOs in order to bring patients from the interior close to the ship so that we can offer surgery. Mercy Ships has the desire to address the global burden of unmet surgical need, as Kelvin has said, in sub-Saharan Africa through two approaches. The direct medical services, which is the surgeries that we offer free of charge to all of our patients, alongside the medical capacity building, aiming to sort of strengthen existing healthcare in the countries that we partner with.
Terrific. Thank you very much. So I think a lot of our listeners are familiar with hospital workflow. So essentially you have a hospital on a boat. I imagine there might be some differences in the workflow. And I was wondering if you could walk us through this a little bit and talk about, are patients handled the same way? Do we have, patients being admitted with an ADT message and like an ORM message that's being ordered for this patient or for the imaging that they're getting? And then, if you could just talk us through, what does it look like as far as the order being placed, the radiologist reviewing it, and then the results being distributed?
Yeah, so the best way to think of Mercy Ships is almost like an outpatient surgical clinic. So we receive referrals from within the country and the local healthcare, and they come to the ship sort of for pre-assessment and pre-diagnostics that are done. So at the moment, Mercy Ships is working with a very paper-based paper charts where everything is written down. And from a radiology perspective, it's paper requests that we have. One of the main challenges that we face is identifying patients. So a patient comes to us, how do we standardize their patient ID, which is the first thing in radiology? How do you confirm that it's that patient? Mercy Ships has a very unique way of using country codes to identify. So for example, we are in Senegal, so we use SN for Senegal, and then we use the letter A, B, C, or D to signify how many times we have visited that nation. And then patients are identified with a 5-digit number. So you have these 3 letters and then the 5-digit number, and that's unique to them. Patient date of birth and address is obviously not so applicable, but we use the patient ID. So the pre-op assessment team will send sort of paper-based referrals, and they send the patient onto the ship to come to radiology. We have a CT scanner, X-ray, Panorex, or the dental OPG, and also ultrasound facilities. So they'll refer them on. We use eFilm, was our DICOM viewer and was our radiology viewer after we perform the examinations, and the surgical and medical team can review the images on eFilm. Most of our imaging is read in-house by our surgical team. However, increasingly, they are relying on the expertise of the consultant radiologists, which are a company we partner with in Alberta. In Canada, they're called medical imaging consultants, and they have a whole group of radiologists who give their time to report our cases. And actually, they provide that service free of charge, because they believe in the work that Mercy Ships is doing, and it's their ability to work remotely and provide these teleradiology services for us. And as I say, they provide these incredible detailed reports free of charge to Mercy Ships.
Thank you for the explanation. This is actually very interesting. And I must ask the next question here from a geeky point of view in my case is, so obviously you've got a unique workflow, and you mentioned a number of parts are done using paper and pen, but then you do have some parts using electronic methods. So I'm curious, for these things, are you actually using off-the-shelf commercial software? I think the one you referred to, eFilm, is Merge, but what about the other components? Have you considered, or maybe even used in the past, custom homegrown solutions or even open source stuff as well?
I can probably address some of that. Up until we deployed the Interlinks solution, we've been using Conquest, which is an open source PACS system. We've used eFilm as the viewer. In terms of moving the images around, we kind of cobbled together a number of solutions. We have a web server with restricted access in Texas. We upload images from the ship to the web server with an FTP client. In the past, we've also used Linux rsync processes in the background. Martha's team, the radiology techs on board, write an email and send that to MIC with the details of the patient and the location of the files. They download it from that website and load it into their PACS system and then process that through. They use a voice capture system for the reports, which then generates a fax, which goes to a fax to email service, which returns an email back to our radiology team on board. And all of that, as you can see, is bits and pieces that we've tied together over the years. All of that process now gets replaced by the Interlinks solution.
And from the Interlinks solution point of view, I can add a bit of insight into where we're going with it. So we're taking a bit of a phased approach right now. Currently, the Conquest PACS has been replaced on the Africa Mercy ship and in a cloud archive. So an archive off the ship has been replaced by Interlinks currently. And we've started the process of working with Mercy ships to customize that and to better the workflows. So essentially today we've replaced the need for Matt and our team in radiology to upload images onto an FTP server, have them downloaded by MIC. That's all been replaced by Interlinks, and basically using an Interlinks network that we've put onto the ship in the cloud and into MIC for those images to be sent across automatically using DICOM. So that certainly alleviated a fair amount of the manual labour in getting the images to be reported. And we're in the process of working with MIC to change the way the reporting is done so that it's all done via HL7 messages rather than fax to email and email and all the manual side of it. So we're peeling it back bit by bit and automating a lot of the processes in place right now and working with Mercy ships to make sure that everything that they need in the unique situations that they have on the ship is accounted for.
Interesting. So I'm going to just jump around on the questions a bit here, and I'm going to ask a question about the transport mechanism of sharing images and reports. I work for a regional health information exchange here in Canada, and often mechanisms that are responsible for sharing images and results, they are pretty good at sending point to point, but often they put a lot of onus and responsibility on the PACS administrator to make sure that it's reconciled against an order, that it files into the PACS properly. Is this the case for this type of solution, or do you have this working in more of an automated fashion so that it seamlessly goes into the PACS as expected?
From the MIC side, we're working with them to get the HL7 messaging piece up and running. There's some work that they need to perform on their end to be able to seamlessly ingest it. So there is a manual reconciliation right now where the email comes through from the radiology department with the information for the patient. The order is manually created and the image is attached to it. But we have a workflow that we're working towards where that will be fully automated. And part of the way that we're having to do that is to consider a session number collisions like anyone else needs to. So we're actually modifying the session numbers to make sure that the ship that they were performed on, there's a code in front of the session number to make sure that it's unique when it gets to MIC.
Interesting. Yeah. I've seen that a lot where people don't account for the uniqueness of the accession number, and then you have collisions happening during the import or ingestion process. Really, really interesting. I'm curious as well. So from the perspective of, you have surgeons, I guess, that are in disparate locations all over the place. Will they have access to be able to review the images ahead of time? Or I guess maybe you could talk us through how it was done previously and what you're targeting for now in this new workflow.
I can explain how it was previously and some of the challenges that we faced. Our surgeons come for a certain number of weeks for a particular surgical specialty, and some of the complex cases that we see involve a lot of assessment beforehand, before surgery. If radiology is so involved and diagnostics in being able to offer safe surgery to the patients, and one of the elements of that is the surgeons reviewing them before they come to operate and seeking advice from their colleagues at their departments at home. So historically, what we were doing prior to the Interlinks involvement is we would scan the patient and we would compress the DICOM files, send them to this website, as Kelvin had alluded to. It was password protected, and the surgeons would be notified by email to say, please download these DICOM files, import them into your own DICOM viewer, and then you can do your assessment. Some of them had software to do that. Some of them just used a sort of free open source reader, but that permitted them to kind of assess the patients before they came. And again, having that partnership with the radiologists as well, we would often be able to send the radiology reports as well, so they could have a comparison of both. A very lengthy process and quite a lot of time on our side, having to copy files for them to be able to view. Thankfully now, with the involvement with Interlinks, we've been able to find a much smoother solution, which I'll let Graeme speak into.
The current workflow that we've implemented, so we've actually implemented Pure Web Resolution MD solution. So it's a zero footprint diagnostic quality viewer that sits within the Mercy Ships data center. And we are making that externally available to surgeons. So they'll have their Active Directory login, the Interlinks login page over public internet connection, wherever they may be. They'll be taken through a level of security. And then from there, they can actually load the patient images and reports in a diagnostic quality, zero footprint 3D viewer and perform everything they need to remotely.
It's quite fascinating, but I'm curious about one small detail, because you talked about transferring images and uploading to FTP and zero footprint viewers. So I'm actually curious. So does the ship then have a satellite internet connection? So like these images are captured on the ship and they're reviewed in Alberta, Canada. And if it is, like what's the speed like, and how did you define what's acceptable for transfer speed and what isn't?
The ship does have satellite, which we use obviously when we're sailing. Actually, right now, one of them's broken, but it's being worked on. But when we come into port, we have land-based connections with multiple providers, usually two. We have a setup in our network called SD-WAN that equalizes all of the different pathways. So the satellite and the two land bases are all multiplexed together. And the SD-WAN software just uses whichever one's got the most capacity at the time. It's kind of like telephone least cost routing, only it's internet instead. And we get somewhere around 50 to 100 megabits per connection ashore, and similar over the satellite. So we can have upwards of 250 megabits, but we're looking at between 400 and 600 people on board a ship. I used to say it's kind of like having a DSL connection at home and inviting 300 of your closest friends around for an internet party. It sounds like a lot. I mean, when we put our first satellite connection on back in 2003 in Sierra Leone, we had 1/4 megabit at that stage, and we did everything across it. Prior to that, we did dial-up with telebit modems. So we've come a long way from there, but so is social media and all the other stuff. And our crew are living on board, and they need to be able to communicate with their families and all the rest of it. That satellite connection also runs 12 telephone lines across it as well. So it's a combination of what we can get through satellite. Of course, geosynchronous satellite's not very good for interactive solutions. It's fine for data transmission, but it's not good for interactive systems because of the propagation delay. So anything that we can do across the shore connection is going to be more responsive in that sense. That's also why we focus on having all our crucial systems hosted on board in an onboard data center, because we can't guarantee that we're going to have those connections. And it's not unusual if one of the providers goes down that the other one goes down at the same time, because somewhere in the infrastructure in the country, they're sharing some service. And I remember, it's been a few years now, but we went into Benin around about 2001, and the only connection for the whole country was a 1 megabit connection. And we were using the local ISP's entire 128 kilobits of that 1 megabit for the nation. But yeah, it's a little better now. The last 7 or 8 years, we've been able to typically get fiber or a good wireless connection between a provider and the ship.
Thank you. Again, quite fascinating. A lot of things that don't necessarily occur to people like me. And along those lines, I'm going to ask a very naive question here. I apologize if it's a dumb question. But you mentioned, about the internet connection, this DSL, it sounds fast, but it's, yourself and your 300 close friends. So that kind of triggered another thought in my mind. What about electricity? Can you actually generate enough electricity to satisfy all this demand? Is that electrical connection reliable? Do you have outages?
Well, we generate all our own power on board. The ship has to, basically, whether it's tied up at the dock or sailing. The only times we use shore power is when we're in a maintenance period, and typically we're in a more stable environment. I mean, we do a lot of our maintenance in the Canary Islands or in Durban, South Africa, and we're in major centres there. We will switch to shore power if we're doing major work on the generators, but the rest of the time we generate our own power. It's a floating city. Think of a cruise ship. We're not a cruise ship, but we have to do all the similar things except for the casino. No casinos on Mercy ships, is there?
This is really fascinating. And so I'm going to ask a question that's not so much informatics related, but you mentioned, that they're living on that ship. You've got the crew and everyone that's, taking the staff or the volunteers of Mercy ships. How long are they on board for? Like, what is a tenure of being stationed on the ship?
2 weeks to a lifetime, right, Martha?
2 weeks to a lifetime, depending on the type of position that you come for. We have some anaesthetists that come for 2 weeks. We have teachers that maybe come for a year, and our chief medical officer, I think Dr. Gary Parker, is he up about 33 years? So generally people don't say that long, but depending on the role that you come for, 2 weeks to a lifetime.
Interesting. Okay, so then now I will get back more on the informatics side. So something that interests me is just the aspect of how there's, different privacy requirements depending on the location that we're based in. In Ontario here in Canada, we have something called PHIPAA. In the United States, they have HIPAA. There's GDPR. In Europe, I'm not familiar with what the legislation is in Alberta, Canada. It would be slightly different than what it is in Ontario. So as a ship that's remote, what legislation do you have to follow, or what do you fall under when it comes to privacy requirements?
I'll start on that, and then Martha, you can talk about the MIC part. Because the ship is flagged in Malta, which is part of the EU, we basically operate under GDPR, but we have to take account of the fact that a lot of our crew are from the US, and so we have HIPAA implications in that with crew-related information. It's complicated because most of the African nations we work in are still working through a lot of those issues. But the best we can do is really work to the most stringent of all of them, and GDPR is pretty much that. I think that pretty much covers it. Plus, Martha will tell you about an agreement that we have with MIC.
Yeah, since we started working with MIC in Alberta in 2013, we developed a memorandum of understanding with them between Mercy Ships' International Chief Medical Officer and the CEO of MIC, setting out some guidance for the responsibilities of both parties, that MIC would report our cases and they would provide that free of charge, with the understanding of who owns the property of the images and the sort of intellectual property or the ownership of the radiology images. All of our patients consent. Obviously, there's consent for surgery, there's consent for medical use of images for teaching and academic purposes, but there is a consent process that the patients go through. In terms of MIC, they have an internal quality assurance program that's ensuring that they use their images appropriately and based on providing radiological reports. So there is an understanding between us in terms of the liability as to who's responsible for the safety and the security of the images that we transfer to them.
Thank you again for that. And I'm curious, we've talked quite a bit now about the workflow. We've discussed the internet connection. I've asked you my naive question about the power. From a security point of view, you've got this global reading workflow. What are the security implications involved in getting all of this working, but also secure?
Well, to start with, we run a VPN from the ship back to our office in Texas, and also where our main data center is, and also to Microsoft Azure, where we're hosting the Interlinks solution. We then have a VPN from Azure to MIC. So all of the data passes through that pipeline between the two ends. For the remote surgeons to have access. We're setting that up with, obviously with SSL to start with, but we're doing two-factor authentication. We're just in the process of implementing that at the moment. So all the connections, all the data transfers are all through protected tunnels.
Terrific. Thank you very much. I'm going to circle back on something that Martha had mentioned a little earlier back when we were talking about patient identity management. A few years ago, I had the privilege of being able to volunteer for RadAid, which is a similar type of mission as Mercy Ships, so serving developing countries and bringing imaging informatics to those developing countries. And in Ghana, there's a challenge where a lot of times patients have very similar names. Their date of birth is not always 100% entered accurately when they're registering at the hospital. So I imagine, birth dates and things like that are still challenging in trying to determine, you have an MRN, but I imagine for repeat visits, it could be challenging trying to associate that this is indeed the patient that previously visited. Has there ever been thought into, biometrics? I believe that there were some areas in developing countries that were looking at like fingerprint to identify, associating like patients together as indeed the same patient as a deterministic way. Or curious about other thoughts or approaches on the patient identity management, or maybe this is not as big of an issue to even tackle. So thoughts?
Patient identification can be very challenging for the patients that we see in West Africa. As I said, about using the country code that we're serving in and which year of the field service that we are there and having the 5 digits, we ask obviously patients' date of birth and we will take an address, but generally it's the patient ID that we rely on. Mercy Ships, generally the procedures that we offer are sort of one-time surgical procedures. So while we do see patients that return to us maybe the next year or a year later for a follow-up surgery, that's actually quite a minimal amount of patients that we see. For those that do come back, obviously we take photographs before and after of our patients and they get a copy of their charts. And so a lot of the patients will, keep a hold of this paperwork and it's very precious to them. So when they hear that Mercy Ships is coming back to their port city, often they will make their way to see the surgeon that operated on them or to see some of the nurses or the team, and they will bring that paperwork with them. So we try to standardize our identification, but it is a challenge. It's definitely a challenge with paper-based systems.
It's probably worth mentioning that names are very, very similar, and so many people don't know their exact birth dates that we have an enormous number of people whose birth date was the 1st of January because we estimate their age in years, but we have no way of knowing when they were actually born.
Another challenge that we face, which you probably won't be aware of, but working in a very international setting, people writing date of birth in numbers was very confusing. So coming from the UK or coming from the States, date of births were always switched around. So even just things like making sure that we write the month that patients say is their date of birth, that solved a lot of our confusion with the way that date of births are written in different countries.
This has been a really good conversation. I think what we could do is just throw it to the group for any kind of closing thoughts.
I would just say the whole reason that we focus on surgery, yes, we do other programs as well, like that our 2 big thrusts at the moment are surgery and what we call medical capacity building, which is a euphemism for providing training for people so that they can carry on and do work after we've left. The whole surgical situation in the world gets overlooked a lot, and WHO are trying to bring focus to that, and we're a part of that because 93% of the people in sub-Saharan Africa have no access to surgery. And part of our efforts over the last number of years, including an international conference we just hosted in Dakar, was to try and bring focus on that whole, most of what you hear about with the Gates Foundation and that is dealing with malaria and all those situations with disease, but the world hasn't brought that same focus onto surgery. Something like 5 billion people in the world don't have access to surgery. And We're dealing with a tiny part of that, but working towards trying to make the world more aware of it. I don't know whether that's relevant to a radiology discussion.
I think it is, yeah.
We wouldn't be doing radiology if it wasn't for the surgeries.
Exactly, yeah.
Yeah, I guess from my side of things, I probably would like to touch on basically why we went with Interlinks and kind of the flexibility that that's given us in order. We have 2 ships right now, but soon we will have 2 ships in operation. And so having that ability that Interlinks has provided, this cloud archive that we can share images across the ships, for me, that's one of the best things that we have achieved out of this collaboration with Interlinks, is that now we can do that. We can, do radiology on one ship and it's in the cloud within 5 minutes. And then, a surgeon on another ship can look at it, or depending on which ship goes back to which country, you have that ability for all the radiology images to be available. And we're in a very unique situation. And it does feel like Graeme and the team really did understand the challenges that we face in working across 2 different ships, multiple different time zones, lots of different languages. It's just all of that. So I don't know how we talk about that, but I think that that's really important for us. And in terms of the future, like, we don't have a RIS, we have a paper system. And so looking towards a sort of, what did you call it, Graeme? It was like the
order entry. Yeah. We're collaborating going forward. We're not just installing a PACS and see you later.
Not at all. No. So for me, that's something that's important. Yeah. Project is still kind of evolving through like discussion and a greater understanding of what Interlinks can provide us, because we aren't even using half of the functionality that is available. We're, just kind of working through this together.
I do have a question though, because it sounds like, you're fundamentally changing something that was an archaic process into, something that is a much more modern process. And often there's an opportunity here where I think you could see like a benefits analysis and really capturing the benefits and the value that's been derived from this. So I'm curious, when you went down this process of doing the project, did you capture like the baseline data of things like how long it takes, the turnaround time, and then you're going to be able to compare that afterwards? And I imagine it's going to be quite stunning, the time differences in all of that. But
yeah, a daily change that it's made in the radiology department. Before, we did measure out how long it took us to copy files, to compress files, to like zip them, to upload them to a system, to let the radiologists know that the images were available. And now with Interlinks, I literally click right mouse and I click move. And that takes how many seconds? So that in itself, if I'm sending multiple radiology examinations to be read every day, that was a lot of time that we were away from the patient and away from interacting with our colleagues. And now we literally click write and send. And that has been such a fundamental change that's really transformed the way that we work.
And if I understand, one of the things you were describing when you were talking to Graeme there is you mentioned order entry. So currently today, I guess the order entry is paper-based. So are you moving towards a more electronic process of having the orders entered and submitted, and that would be through the same vendor?
Our goal is to have a full EMR in the hospital, but we've had a bit of a hiccup on that path. And so we're backing away from that for the moment while we re-examine where we need to go. And in the meantime, Interlinks have suggested that they could provide a way to capture the content of the paper so that Martha's team don't have to manually enter that into each modality. So it would be a sort of a mini RIS, I guess would be one way of putting it, or at least a data capture front end onto the Interlinks system. It's still manual capture within the radiology team, but at least they do it once instead of multiple times.
To be able to facilitate moving forward with the workflow with HL7 messaging and making it all seamless, the paper-based system doesn't really end there. So we started to peel it back bit by bit. So one of the things that we done recently with the go live on the Africa Mercy ship, modalities, there's no work list, there's no risk, so there was no session numbers. So exams were coming through to PACS without session numbers. So we've remedied that. We're generating the session numbers on the Interlink side. We're putting them in. The idea with the EMR was that Interlinks would then start providing the modality work list based off of the orders. But we've worked together over the past 12 months on this project. We've went from the kind of the requirements of getting the 2 ships online with PACS and the cloud PACS and getting it connected to MIC, and started to work alongside Mercy Ships to expand that out into, okay, it makes sense for us to step in and give some sort of order entry so that the radiology department can enter the orders into Interlinks. We can then use that information to generate the HL7 messages through to MIC with all the clinical information to be reported on and take away that email component. We're peeling it away bit by bit. And the funny thing is where you would normally see in healthcare, it's pushback on changes to workflow and pushback to implementation of new technology. I think, Martha, can tell you that the people on the ship are like, okay, that's great, that bit works now, what's next? What can we do next? It's good to work with people that are eager to implement all these changes in the technology.
So I want to take a moment and thank each one of you for your time today. Graeme, Kelvin, Martha, it's really genuinely been an enlightening episode. I've learned so much from you today, and it's quite eye-opening for me. Happy to hear from each of you if you've got any other closing thoughts. Again, we appreciate your time today. And of course, if you can let our listeners know how they can find out more about Mercy Ships, ways they can get involved, whether to donate or volunteer, that would be highly appreciated. Thank you so much.
I'll go first and say how much we've appreciated this opportunity. Listeners can find out more about us by simply going to our website, www.mercyships.org. All the information on donating and volunteering is on that website. That pretty much covers that. Martha?
Yeah, I would just encourage some of our listeners to think about radiology and how we can work internationally and serve patients all over the world by using the systems that are used in sort of high-income countries. And we have this opportunity to provide the same level of service to our patients in West and Central West Africa. With the fact that we now have 2 ships in operation, having this cloud-based and this web-based solution for our PACS with Interlinks just really is making such a difference for us as we continue to serve the patients here.
Thanks to everyone working with Mercy Ships from the Interlinks point of view. Is and it continues to be a pleasure over the last year. And we're excited to continue to work with these guys and see what we can make happen.
Well, thank you very much. I think this is quite an amazing thing. I think you have on your hands an amazing project. It'd be interesting to see. I think this could make a very captivating presentation at SIM 23 or something like that. Happy that everyone was able to join today, and thank you very much.
Simcast has been brought to you by the Society of Imaging Informatics in Medicine. Please visit our website at siim.org for more information and educational content, including webinars and an archive of prior episodes. Please follow us on Twitter at sim_tweets. Thank you to our listeners for your continued support.